Hello, everyone, and welcome to the Academy for Eating Disorders webinar entitled Weight Bias, Internalization, and Eating Disorders. What do we know and what do we do with Dr. Rebecca Pearl. My name is Caitlin Martinwager, and I'm your moderator today. Also with us is Ronald Fan, AAD's membership manager. If you have any questions or concerns about this webinar, please feel free to reach out to Dawn Gannon at AAD headquarters via email at dgannon@aedweb.org. And just a couple of quick housekeeping items before we get started. All participants are muted with the exception of the speaker and myself. The webinar is scheduled for 60 minutes and it is being recorded. It will be posted on the AAD website shortly thereafter for AAD members to download at their convenience, 24 hours a day, 7 days per week. In just a few minutes, Dr. Pearl will begin her presentation, after which she will answer questions from the audience. So please feel free to submit your questions to the speaker during the presentation using the Q&A text box, which is at the bottom middle of your screen. And then I will then read those questions to the speaker when the question portion of the webinar begins. Dr. Pearl, let's check your volume quickly. Please just say a few words. And if a couple of participants can let me know if you hear them clearly by sending a message in the Q&A text box I just mentioned, we can get started.
Hi, Caitlin, can you hear me?
I can. Let me check to see if others are hearing. Yep, looks like they can. All right, let's see. Thank you everyone for letting us know that the volume level is good. And let's begin by introducing our speaker. Rebecca Pearl, PhD, is an assistant professor of psychology in psychiatry at the Perelman School of Medicine at the University of Pennsylvania. Dr. Pearl received her BA from Duke University and her PhD in clinical psychology from Yale University. Dr. Pearl's research focuses on weight bias and its associated health outcomes. She also investigates strategies for reducing weight bias and its internalization. Her work is currently supported by a K-23 Mentored Patient-Oriented Research Career Development Award from the National Heart, Lung, and Blood Institute of the National Institute of Health. So without further ado, Dr. Pearl, the audience is all yours.
Wonderful. Well, thank you, Caitlin, and to AED for inviting me to give this webinar today. I'm very excited to talk to this audience about the topic of weight bias. So today I'll give an overview of weight bias with a particular focus on its internalization. I'll also discuss the implications of weight bias for health and in particular its implications for eating disorders, and then end with a discussion of some of the emerging evidence in support of different interventions to address weight bias. So to start with an overview, I wanted to lay out some terms and some definitions just to get everybody on the same page. So when I talk about bias, I'm referring to negative attitudes or prejudicial attitudes. The term stereotypes usually refers to assumptions that are based on overgeneralizations that contribute to bias. And the term stigma, which sometimes people use interchangeably with weight bias and stigma, but stigma is kind of classically defined as devaluation of a quote unquote deviant social identity based on some distinguishing characteristic. And then there are different forms in which stigma may appear. So there's anticipated stigma, where maybe someone hasn't actually had an experience of being teased or bullied or discriminated against, but they might expect it to happen or worry about it happening. Then there's enacted stigma. So this is when there is an actual experience. So it's often called experienced or perceived stigma. And then internalized stigma, which I'll spend more time talking about. So these terms in their application to weight bias refers to negative attitudes toward individuals who are perceived to have excess weight. Certainly people of other weight statuses can be the target of negative attitudes, particularly we know that men who are underweight tend to get negative attitudes directed toward them as well. But generally, when we're talking about weight bias, we're talking about negative attitudes toward people who have a higher weight or who are categorized as having obesity. And another point about terms, I will be using terms such as obesity and BMI and higher body weight while also acknowledging there's an ongoing and important discourse in our field that's happening now about what are the most appropriate terms to be using. The stereotypes that often come up with regard to weight are that people are lazy, they're not as intelligent or organized, they don't have self-control or willpower based on their weight. There's a lot of blame that's placed on people because of their weight, and you hear this term personal responsibility thrown around a lot, with the idea that people should be able to control their weight. And if someone is not able to control their weight, then that means they're an irresponsible person or they're a weak person. And as a result of these negative attitudes, we see people being devalued or ostracized because of their weight, and that's really the stigmatization. We can also think about the different levels at which stigma may occur. So if we start with the broadest level, the structural level, or sometimes called institutional stigma, this is where we have things in place in society that perpetuate stigma or that don't protect or prevent stigmatization. So one example at the structural level is the media. So we very commonly see these kinds of stereotypical portrayals of people engaging in unhealthy eating habits, or these unflattering close-ups of body parts with the heads cut off in this very dehumanizing manner. And then in popular television shows and movies, the overweight characters are often the butt of the joke. They're portrayed as slow or undesirable. And then, of course, with social media, we have a whole other forum with which people can be blamed and shamed because of their weight. We can also see examples of stigma in public health campaigns that perhaps were well-meaning at the start, but have these unintended negative consequences of perpetuating stigma. Another example at the structural level would be policies that perpetuate stigma. So this is an example of a Texas hospital that very openly said it would not hire applicants with a BMI of 35 or above. And this is entirely legal, that there are no federal laws or state laws in Texas or any city laws in Texas that would prohibit this kind of discrimination, which I'll talk more about later on in this webinar. But you can see at the bottom, the hospital justified this decision by saying that every employee should fit with a representational image or specific mental projection of the job of a healthcare professional. So very blatantly discriminating against people because of their appearance or their weight. Another form of structural stigma from a policy perspective can occur in healthcare with this type of example. So this was an announcement in 2017 from the NHS in the UK, announcing that patients with obesity would not be eligible for non-urgent surgeries until they lost weight. And there were specific instructions of how much weight people had to lose based on their body mass index. There certainly are policies like this that are used in the US, maybe not as institutionally, but you often hear of surgeons who won't operate on a patient for a knee replacement until they lose a certain amount of weight, or even for bariatric surgery, some insurance companies will require evidence of weight loss prior to being eligible for surgery. We can go down to the interpersonal level. So this is between individuals. And here we have examples of stigma like social rejection, social distance or avoiding people because of their weight, teasing or bullying, especially among youth. Weight is the leading reason for teasing and bullying in youth. And then also discrimination between individuals. And just to give you a sense of the prevalence of discrimination based on weight, there can sometimes be a misconception that as obesity rates are rising and as there are more messages about weight acceptance in the media, that people have become more accepting of people based on their size and there's less discrimination. And I will say that in the last couple of years, I certainly have seen progress in the attention and awareness to this issue. But I'll show you data that corresponded with increases in obesity rates in the country, but also showed changes in rates of discrimination, such that weight-based discrimination increased from the late 90s to the early 2000s substantially. So as obesity rates are rising, so are rates of weight-based discrimination. And if we break it down by gender, we can see that among women in the gray bars, rates of weight-based discrimination are comparable to those of race and age-based discrimination. So this is a very prevalent form of discrimination. And some estimates report that up to 40% of people with obesity report experiencing weight discrimination. Those estimates vary by study, but certainly women and people with the highest BMIs tend to have the highest prevalence of weight discrimination. Here are some real world examples from the past few years. So this was a tweet from a psychology professor saying that he would not consider obese PhD applicants because they would not have the willpower to do a dissertation. This was an example from a couple years ago of a woman who wouldn't let her daughter attend a preschool with an overweight teacher because she thought she'd be an unhealthy role model. This was from this past January, a scene that went viral of a passenger on a plane who was heard loudly talking about the passengers beside her in a derogatory way because of their weight. And this is kind of a classic example of social distance, not wanting to sit next to passengers because of their higher weight. The last level that I'm going to focus mostly on is the intrapersonal level, or within the individual. And this is really what we're talking about with internalized stigma. So there are many different names for this construct that all generally refer to the same thing. So you might hear weight bias internalization, or self-directed weight bias, or self-stigma. But this generally refers to the phenomenon of people who have a higher body weight being aware of all these negative societal messages about them because of their weight and starting to believe that they're true. So endorsing the negative stereotypes related to weight, applying those stereotypes to themselves, and then as a result, having a lower self-worth or more negative self-evaluation because of their weight. I'll give you some examples of quotations from the HBO series Weight of the Nation, which in addition to its main documentary also has 15-minute shorts, and they have one on weight bias that's available online. So here are some quotes from people who were interviewed as part of this segment that I think can exemplify this issue of weight bias internalization. So one man said, no matter how many friends I had or how good I was at what I was doing or how successful I was, I always felt that I wasn't successful enough or had enough friends or people really liked me because I was overweight. Another woman said, I hated myself more than people hated me and were made to feel like we're worthless. So I also want to highlight here the difference between weight bias internalization and some other forms of internalization that are often discussed in the eating disorders context. So like internalization of the thin ideal or sociocultural norms about weight. And certainly those are all related to weight bias and a part of this bias. But with weight bias internalization, it's not only a dissatisfaction with one's body, but it's really believing that as a person, someone is less worthy or less good than other people just because of their weight. Weight bias internalization is typically measured with two scales. So the main one is the weight bias internalization scale, developed by Durso and Latner. This scale has 10 or 11 items, depending on which version is used. There have been some issues with psychometric properties, including one of the items. And the items are scored from 1 to 7 and average. So this first item is the one that can be removed or included. And there's also a modified version of this scale that's weight neutral. So essentially some of the items in the original scale included the phrase like, for being overweight. So we just replaced that with a weight neutral term of, instead of I hate myself for being overweight, I hate myself for my weight. And in that way, the scale can be disseminated to people who may not necessarily identify as being overweight. The other scale that's often used is the weight self-stigma questionnaire developed by Jason Lillis. So this has 12 items, and you can have a total summed score for a total score, but you can also break it up into subscales. So the fear of enacted stigma subscale includes the anticipation of stigma, whereas the self-devaluation subscale is more getting at that negative self-evaluation because of one's weight. There's not a lot known about the prevalence of weight bias internalization, and in general, this is a newer topic for research in the weight bias and stigma realm. But there have been a couple of recent studies that have tried to estimate the prevalence based on use of these scales, namely the weight bias internalization scale. So one study that was conducted by Rebecca Poole found that almost half of US adults have some level of weight bias internalization, and about 1 in 5 would be categorized as having particularly high levels of internalization. We also know that weight bias internalization tends to be higher in treatment-seeking samples, so patients who are seeking weight loss treatment, but especially in patients with binge eating disorder and patients who are seeking bariatric surgery, you tend to see the highest levels of weight bias internalization. One tricky issue is that there's no established clinical cutoff on these scales. So this is a very important topic for future research to really try to understand what is clinically significant weight bias internalization. We can also start to think about who might be most at risk for internalizing weight bias, or try to build a phenotype, if you will, of the type of person for whom weight bias internalization is particularly salient. And we don't have any longitudinal data at this point on this, so I'll make that clear that the findings I'll present to you are from cross-sectional studies. But we are starting to take a look at what might be some risk factors. So in surveying both patients who are involved in treatment studies and also commercial weight loss participants, we've found some potential factors that might be related to weight bias internalization. So women, younger folks, and people with higher BMIs tend to have higher scores on these weight bias internalization scales. People who have a younger age of onset, both of feeling like they're overweight, but also of having experiences of teasing or negative comments about their weight. And we know that anybody who experiences weight stigma has higher levels of weight bias internalization than people who don't experience weight stigma. But we're also finding that the amount of distress following these experiences of weight stigma might be particularly important. So there are some people who might experience weight stigma and don't have as high levels of distress, and those folks might not be as likely to internalize weight bias. And this might be especially true for ongoing or more recent experiences of weight bias. So it might be a combination of having a younger age of onset of weight stigma, and then also having recent experiences of stigma and distress related to that, that together increase this risk for weight bias internalization. There are also some sociocultural and family factors that we've started to identify. So experiencing stigma, particularly from family members or in work settings, seems to be associated with higher internalization. And in one study, we found that patients who reported that their mother had a higher body weight had lower levels of weight bias internalization. So maternal body weight could potentially be a related factor. And I'll highlight that these findings are based on cross-sectional data. We don't know whether any of these factors predict over time the onset or increased risk for internalization. A longitudinal study would be important, although there is some evidence that internalization begins at a very young age. So it also might be difficult to capture the exact onset of this weight bias internalization, given that very young children seem to be aware of these kinds of negative weight messages. We've also examined a bit weight bias internalization across body weight categories. So as I mentioned, when we're talking about weight bias, we're usually thinking about people with the higher weights, the highest levels of BMI. But with that weight bias internalization scale, we did a study of about 150 men and women, and we looked at the differences in the scores by BMI category as well as by self-identified weight status. So I recognize that BMI is not a perfectly objective measure of weight or health status, so we looked at this both ways. But generally what we found is that people who had the highest BMI, as a BMI of 30 or above, which would be categorized as obesity, they scored the highest on this weight bias internalization scale. And people who were in the BMI range of 25 to 30 had greater scores than people who had BMIs of 18.5 to 25, so people in that quote unquote normal range or leaner range. But what was interesting is we didn't see a difference in weight bias internalization between people who were in that overweight range and people who were in an underweight range. So that's interesting. And again, even when we looked at self-identified weight status, these findings held. So this is an area that I also think, could be investigated more, of administering this type of scale or investigating this idea of weight bias internalization among people who have lower body mass indexes or lower weight statuses. And this is also especially relevant for looking at eating disorders. So that'll bridge into the next section, where I'm going to talk more about the implications of weight bias for health and in particular for eating disorders. So very broadly, we know that there are a number of negative effects of discrimination of any kind, including for weight. So when people face discrimination, they have less educational achievement and advances, they have lower wages, greater unemployment, and these findings have all been found in relation to weight, even when you control for other socioeconomic factors or health factors that might contribute to, say, unemployment rates. So above and beyond other factors, weight discrimination is playing a role in this loss of socioeconomic opportunities. And because SES and health are so intimately tied, the effects of discrimination therefore have an indirect effect on health by, preventing socioeconomic advancement. We might be also having a negative impact on health. But then there are also more direct implications of stigma on health. It's generally been pretty widely accepted that stigma in general is a form of chronic stress. And there have been a number of efforts to reduce stigma for other kinds of stigmatized populations, like due to mental illness or addiction is a big topic right now that people are talking about, trying to reduce stigma to increase treatment. And yet for obesity, even in health communities, there sometimes is this lingering belief that if people were not stigmatized or if people felt too good about their bodies, then they wouldn't be motivated to take care of themselves or to engage in healthy behaviors. And so some people worry that, maybe just a little bit of stigma might actually be necessary to keep people motivated to improve their health. So if there's anything you take away from this webinar, it is that that is not true, that weight stigma does not motivate people to become healthier. It has the opposite effect. So I'm going to briefly walk through this diagram just to summarize the findings in the literature. And there have been a lot of studies that are, just briefly summarized in each of these bullet points, but just to give you a sense of where we're at in terms of what we know about how weight stigma affects health. So as I said, weight stigma is considered to be stressful. And when people are under stress, they tend to eat more. When people are stressed, they also tend to not be as physically active. And especially if people have that anticipated stigma of being judged or criticized in a physical activity setting or in public when they're exercising, that leads them to avoid being active. There's also a physiological stress response that affects things like cortisol and markers of inflammation, which themselves can be health risk factors, but also have implications for things like appetite. So when cortisol changes, that can increase appetite, which then can lead to more eating or more binge eating. So together, the behavioral and the biological responses to stress actually lead to more weight gain over time. And there have now been several longitudinal studies that have found this relationship between weight discrimination and more weight gain over time compared to people who do not perceive weight discrimination. There are also a number of psychological outcomes associated with experiencing weight stigma, such as depression, anxiety, poor body image, substance abuse, and suicidality, particularly in youth. Healthcare can be affected by weight bias. So if a patient feels judged or criticized by their provider because of their weight, it makes it less likely they're going to follow their recommendations or return to them for future care, or maybe return to any doctor or seek out preventative services when someone's had a really negative experience like that in a healthcare setting. And weight bias also impacts the quality of care that people receive, or the decision-making of the physician and the communication between the physician and the patient. So taken together, there's just more and more evidence continuing to emerge that experiences of weight stigma are negatively associated with health-related quality of life. So they do not improve care and improve health outcomes. They have the opposite effect. I could not make that clearer. And something that we've been starting, I'll back up and mention for a moment a much simpler model of this from Janet Tomiyama of the Cobwebs model, where you can see weight-based stigma leading to stress, which leads to increased eating and cortisol, which leads to more weight gain, which then perpetuates the cycle of then being stigmatized more, and so on and so forth. So this is a very nice, easy to follow model. So we've been starting to try to look at weight bias internalization and its relationship to health outcomes, which really hasn't received as much attention. And part of it is that methodologically it's harder to measure this internalization versus just a yes or no item of have you ever been discriminated against because of your weight. So measures of internalization really haven't been incorporated into large-scale epidemiological studies in the same way that discrimination measures have been. But we have some preliminary evidence that there might be a similar relationship. So these are data from a study that we did at Penn a couple years ago where we had patients who were seeking weight loss treatment, and we measured weight bias internalization at baseline as well as assessed for the metabolic syndrome, which for those who aren't familiar, this is a cluster of symptoms that are associated with increased cardiovascular disease risk and diabetes. So this includes blood pressure, HDL cholesterol, glucose, triglycerides, and waist circumference. And if people have 3 of the 5 risk factors, then they might be diagnosed with having the metabolic syndrome. So what we found in this patient sample is that people who had the highest levels of weight bias internalization were much more likely to also have metabolic syndrome than people who had lower levels of weight bias internalization. And when we looked at each of those criteria of the metabolic syndrome, we found that triglycerides in particular tended to be associated with weight bias internalization, with people with the highest levels of WBI having 6 times greater odds of having high triglycerides or being on medication for it. And these effects held even when we controlled for body mass index, depression, and demographic factors. So this is a finding that needs to be replicated and needs further probing, but it's possible that there may be a biochemical stress response similar to what we see when people actually have experiences of discrimination versus just internalizing the bias. It also might be that when people internalize negative beliefs like they're lazy or they have no self-control, that they have less self-efficacy or less confidence in their ability to make healthy food choices or to go for the walk they were planning to go on during their lunch break. And so it might be that through this psychological pathway, people are engaging in less health behaviors because of their high levels of internalized bias. So I'll move a bit more toward talking about eating disorders in particular and some of the evidence. So we do know that people who are disparaged beginning at a young age, that those folks have more disordered eating symptoms later in life. So there is this association between early life negative experiences with weight and more unhealthy eating behaviors later on. So as an example, the study by Jeff Hunger and Janet Tomiyama showed that when girls were labeled as being too fat at age 14, they were more likely to have disordered eating at age 19, particularly if that labeling came from family members. And then, of course, I'm sure most of the people in this audience are aware of Project EAT and all the important findings that have come out of that work. So just a summary of, the main take home from that is that weight teasing predicts increased disordered eating over time. I'm not going to spend much more time than this going over the relationship between teasing and disordered eating, mainly because I think this audience is probably already very well versed in this information. So I'd like to talk more about internalization and disordered eating, because there have been studies that have found associations between weight bias internalization and binge eating, purging behaviors, drive for thinness, emotional eating, and addictive-like eating symptoms. And if we think about Fairbairn's classic model of eating disorders, we might ask, well, where does weight bias internalization fit into this model? If there's a room for it at all in here. So might it be worked into this idea of the dysfunctional schema or the core low self-esteem? Can weight bias internalization fit into this somehow? And there is some evidence that, you know, these kinds of constructs are related, but they're not quite the same thing, but that there might be some kind of cyclical process that happens here. So for example, this is a model from a study I did a few years ago looking at patients with binge eating disorder. So among these patients with binge eating disorder, we found that people who had lower self-esteem had more overvaluation of shape and weight, who then also had greater weight bias internalization. So I think this is, you know, a jumping off point to think more about how weight bias internalization might be different and might be similar to some of the already established concepts that we think about in eating disorders. It's also important to think about among people with eating disorders how weight bias and its internalization might affect overall well-being and perhaps exacerbate health issues. And a lot of this work has mostly been done in folks with binge eating disorder, again, because weight bias is typically viewed in terms of a higher body weight, and we know that there is a high comorbidity between binge eating disorder and obesity. So that's where I'm coming from in presenting this work, but I think there certainly is room and a need to investigate this more in patients with anorexia or bulimia. But we know in folks with binge eating disorder, there is a heightened body image disturbance, and as I mentioned before, weight bias internalization tends to be high among these patients. So these are people who are maybe more at risk for weight bias internalization than the general population or just other people who have a higher body weight. It's also interesting to consider the role of depression, because a question I often get is, isn't weight bias internalization just the same thing as depression? And certainly it's associated with depression, but it's not the same thing. And the correlations are not perfect. They're, you know, small to moderate. So they're related, but I don't think they're the same thing. I think these are two separate phenomena. And so patients with BED are at increased risk for depression as well. And we know that body dissatisfaction is also related to depressive symptoms. So all these concepts are interrelated. And we also know that depression is associated with poor physical and mental health, of course. So we wanted in this study to investigate the relationship between weight bias internalization and health-related quality of life, and look at the role of depression in this relationship, specifically among patients with binge eating disorder. So really trying to identify what's the impact of weight bias internalization on health within an eating disorder population. And we predicted that internalized weight bias would be associated with worse health and that depressive symptoms would play a role in this relationship. So the sample for this study was 255 treatment-seeking adults who were all had a diagnosis of BED and were seeking weight loss treatment. And those diagnoses were established through doctoral level clinician-conducted diagnostic interviews. And all the participants had their height and weight measured to compute their BMIs and then completed self-reported questionnaires. So we had the weight bias internalization scale, which I've described, the Beck Depression Inventory, as well as the SF-36, which is divided into two sets of subscales, a physical health scale and mental health. And so there's 2 component scores that are computed, as well as 4 subscales within each category. So the physical component score was a summary of physical functioning, one's ability to fulfill their roles because of their physical health, bodily pain, and general health. And then the mental health component score summarized vitality, social functioning, ability to fulfill one's roles because of emotional well-being, and mental health. And what we found when we ran regression models that included and or did and did not include BMI in the models, regardless of whether or not BMI was in the model, weight bias internalization was negatively associated with all of these indices of both physical and mental health. Weight bias internalization was also associated with the mental health component score, although it was not significantly associated with the overall physical health component score. And then when we tested the mediation models for each of the different components for physical health, we did see a relationship such that weight bias internalization was associated with more symptoms of depression, which was then associated with worse physical health. And then likewise, we saw weight bias internalization also mediating the relationship, or I'm sorry, depressive symptoms mediating the relationship between weight bias internalization and the mental health subscales. So at this point, I've talked about the overall prevalence of weight bias, what it is, how many people it affects, and also the implications of these experiences and especially its internalization for health, including in the context of eating disorders. So I'm gonna end by discussing some of the evidence for different interventions to address weight bias. So if we think broadly about the different kinds of goals that we might have in addressing bias and stigma, so for one, we want to change public attitudes. We also want to target people who are in structural or institutional positions of power, such as employers or teachers or healthcare professionals, so that they are not perpetuating stigma or stigmatizing their employees or students or patients. We also might want to change the attitudes of stigmatized individuals to reduce their internalization or their self-devaluation because of their weight. And then we can also think about creating policies to prevent or reduce these downstream negative consequences of experiencing discrimination. So if we break those broad goals down into specific initiatives, some of the strategies that have been proposed and investigated include changing media portrayals, emphasizing biogenetic causes of obesity to reduce blame. This is a fairly controversial approach, and I'd say the jury's still out on whether or not this is actually effective. So the intention is that if something is genetic, it's not in a person's control, and so that should reduce blame. This approach has been used with other stigmatized groups, like based on sexual identity. However, there certainly are people who disagree with this approach and just the general medicalization of obesity. So this is a controversial approach, but I'll just mention that this is one that is being investigated. Other approaches are this idea of increasing positive contact. This comes from intergroup relations theory, or trying to increase people's empathy for other people who might struggle with their weight or feel down about themselves because of their weight. Incorporating more training into healthcare institutions to both educate healthcare professionals about weight, but also how to talk about weight, how to be sensitive about it and not perpetuate stereotypes or stigmatizing comments. I'm going to focus mostly on these two pieces, so psychological interventions and policy solutions, since these have been investigated particularly in the context of weight bias internalization. But I just want to, emphasize that I think all of these approaches are important, and of course we want to change societal attitudes so that people are not being stigmatized or don't have negative messages to internalize. And at the same time, I think we also need to think about the people who have already internalized these messages and how do we help them cope with this or reduce their suffering. So there are different approaches that have been used within the subheading of psychological interventions. The first being a cognitive behavioral approach. And this is an approach that I have used. My background is in cognitive behavioral therapy and related third wave therapies. So one thing that we've been working on at Penn is the weight bias internalization and stigma program, or the bias program. So I'll talk with you today about some of the pilot data that we have for this program that was tested in a very small study, but with some promising results, just to make you all aware of what we're working on currently. So in this program, it was an 8-session program, so 8 weekly group meetings, and I'll talk about each of the topics. So we talked about psychoeducation for weight and weight bias, so actually introducing people to the idea of weight bias because they may not have heard of it talked about in this way. Challenging myths and stereotypes, so really diving into what's the evidence for and against some of these stereotypes, and then also identifying cognitive distortions using thought records. So these are really kind of classic CBT techniques tailored specifically to address weight bias and its internalization. So if any of you have never seen a thought record, this is what it looks like, but it really standard strategy of identifying a situation, in this case specifically a situation where someone felt stigmatized or someone made a negative comment about their weight, or they just had a negative thought about themselves because of their weight, looking in the mirror and having a thought, I'm fat and disgusting, for example. So they had to identify the thought, identify what they were feeling, how intense that emotion was, identify if there was a cognitive distortion, and then coming up with an alternative thought. So what's a more balanced or neutral thought to have, or a more accurate thought to have, and then re-rating their emotion with the idea that when they change their thoughts, they'll also change their feelings. We did the classic CBT triangle of the relationship between thoughts, feelings, and behaviors, but specifically for the context of weight bias experiences, and then thinking about how to restructure those negative thoughts or reappraise the stigmatizing situations. So this is an example of a handout we might have used, identifying negative thoughts in the face of weight bias, like, they're right, I am lazy, I'm a failure, I'll never do X because of my weight, I'll never get the job I want or find love because of my weight. And then some of the associated feelings that might go with that of sadness or shame or anxiety and physical sensations. And then also some behaviors. And we focused on health behaviors because many people did report, and we know from the literature that when people feel this way, they might eat more or avoid being in a physical activity setting, or also just simply withdraw from other people in general. And then the goal for participants was to identify these different patterns and then come up with a new thought and then re-rate their feeling and come up with an alternative behavior that they could use to cope. We also included assertiveness training. So when someone did make a comment to them about their weight, or when they felt like they were discriminated against, what did they do? What do you say in that moment? This is not often discussed, of like, well, how do you actually respond? Or, you know, if someone's mother makes a comment about what they're eating every time they have dinner, how do you actually script a conversation to ask that person in your life to stop making those comments or to behave differently toward you because of your weight? We talked about reducing self-criticism, building up empowerment, including by getting involved in advocacy. It's been proposed that, you know, advocacy and empowerment is kind of the antidote to internalization. And I'll talk a bit more about that at the end as well. And then also talking about self and body acceptance. And this really was a skills-based program. So we ended with a review. People built a coping plan for themselves of, you know, if they have an experience of weight bias or a negative thought about themselves because of their weight, what skills are they going to use to respond and cope with that? So here are the data from this study. It was, again, a very small study. We had 8 people in this intervention group, and then we had a quasi-control group of 6 people who did not receive the intervention until the end. It was a pretty diverse group, and everybody had a higher body weight in both of these groups. Our primary outcome was the weight bias internalization scale, which I've described. These are some other examples of items. We also included the fat phobia scale, which assesses stereotype endorsement, the weight self-efficacy scale, which assesses people's confidence in their ability to prevent themselves from overeating or to have control over their eating, the BDI, and then also treatment acceptability ratings. So as far as our results, we found that in that weight bias program, we saw about a 1-point reduction on the weight bias internalization scale, and this was significantly different from the control group where we did not see any changes. We also saw a significant reduction in endorsement of negative weight stereotypes. We saw a significant increase in that weight efficacy scale, which is interesting because we really weren't giving any kind of intervention for how to prevent overeating or how to change one's eating habits. We talked about the connection between these negative thoughts, feelings, and eating behaviors, but just by reducing the internalization or addressing weight bias, it seemed to increase people's confidence in their ability to control their eating. Depression, we did not see a significant difference. It looks like we did in the intervention group, but you can see there's a lot of variability. You can also see that overall our patient sample was, you know, fairly depressed, of BDI scores in the 20s on average. And so this intervention wasn't designed to be a treatment for depression, and yet it is possible that maybe in a larger sample, we might see some differentiation in these groups. And overall, the acceptability ratings were really high. People really liked the program. So what we're working on now is testing this program in a larger sample in longer term studies to see how robust these results might be, and also to consider whether or not this kind of program might be incorporated into a weight management setting where we might be able to target people who are most vulnerable to internalizing these kinds of negative beliefs. I'll briefly mention some of the other approaches that have support for reducing weight bias internalization in terms of psychological interventions. So there are acceptance-based approaches that are less focused on identifying and challenging negative thoughts, but more about mindfulness, self-compassion. So ACT is kind of the commonly used vehicle for delivering this kind of treatment. And I know many of the people in this audience are likely familiar with ACT. So in terms of the studies that have been done, there was one open label trial of ACT in combination with a health behavior and weight management intervention with self-guided coaching, self-guided intervention with coaching calls. That was also a small short-term study. And then there was an RCT of ACT plus a mindful eating intervention versus treatment as usual medical or nutritional visits. And in both studies, they found significant improvements in weight self-stigma and health behaviors, and those improvements were sustained at a 3-month follow-up. So this is also another promising approach. The last approach is the non-dieting approach or weight neutral approach, which I think many people in this audience will also be familiar with. So this is the idea of intuitive eating without caloric restriction. Health at Every Size is probably the most well-known program of this nature. And there really is this promotion of body and self-acceptance. There is a discussion of stigma and coping. And in one study by Robert Carrells, they did actually include a session specifically on weight bias internalization. And these studies have also found improvements in weight bias internalization, self-esteem, body image, health behaviors, and other markers of health. I'll turn to the issue of policy briefly too, because this has implications for preventing discrimination, but also potentially for improving psychological well-being. So both in terms of policies of anti-discrimination legislation and also anti-bullying policies. So to give you a lay of the land, there's very little protection against weight-based discrimination in the US and abroad. So Michigan is currently the only state where it is illegal to discriminate in this way. I know there have been some hearings and a lot of advocacy in Massachusetts, so hopefully that's something that has a successful outcome. And then a handful of cities also have these kinds of laws, and there's a lot of support in this country for this kind of legal protection. As far as bullying goes, there's only one state, Maine, that actually specifically includes weight in their anti-bullying legislation, and a few other states do mention physical attributes or appearance. And there was a systematic review of anti-bullying curricula in schools, and they found that not a single program actually specifically targeted weight-based bullying, which is really striking considering this is the leading reason for bullying in schools. So, as I mentioned, policy and legislation is important for preventing these instances of discrimination and bullying, but there might also be a psychological effect. So there's a construct in social psychology called belief in a just world, which is this motivation that we all have to think that the world is fair and just. And when we think this way, we tend to be happier. We have better psychological well-being. And we had done a study among people who had experienced weight bias, finding that when you threaten this belief in a just world, people report greater weight bias internalization, particularly if they think weight discrimination is pervasive. So when people experience weight bias, they think it happens all the time, and they think the world is unfair, they have higher weight bias internalization. So legislation might be an antidote to that, because legislation gives a message that it's not okay that this happened, and it gives people a sense of justice. They can do something about it if they'd like. They have legal recourse. And so it's possible that legislation in this way might reduce self-blame and increase empowerment, and therefore perhaps reduce internalized weight bias. And there's some evidence for this theory from sexual minorities, where we know in states that have better legal protections for sexual minorities, they have better mental and physical health. And we did a preliminary online study testing this idea in the context of weight discrimination, where participants read about a vignette of weight discrimination and were either told that discrimination was legal or illegal. And when they were told it was illegal, they had lower weight bias internalization and just generally less negative affect. So this is a preliminary study. It needs to be tested in the real world, but it suggests that policy may have this kind of implication. So to summarize what I've talked about, for one, weight bias is pervasive, and we really need more research to understand its internalization. So there's a lot we don't understand about the prevalence and who's at most risk for internalization. The interventions to help people who have internalized weight bias are lacking, but some of the emerging psychological interventions and even policy initiatives might be promising for reducing internalization and the negative downstream consequences of experiencing weight bias. So before I end, I just want to talk briefly about healthcare professionals and advocacy, since this affects everybody in this audience. So unfortunately, I think we're probably all aware that weight biased attitudes have been documented across all health settings, including among people who specialize in obesity and eating disorders. So just having knowledge in a field doesn't prevent someone from having some of these biases. And biases are part of being human. We all have biases of some kind. So it's really important, especially as healthcare professionals, to be on top of those biases. So to educate yourself and others, and this is where being an advocate comes in. So, you know, if you hear colleagues making insensitive remarks about weight, you can educate them, challenging your own and others' negative attitudes or assumptions. If you are in a healthcare setting where weight is discussed with patients, thinking about using open-ended questions like, how is this weight for you, rather than putting your own judgments onto a person because of their weight. Generally focusing on behaviors and health rather than weight and appearance, taking an extra moment to express empathy and validate and give encouragement when people are feeling down about their weight, especially if you consider the likelihood that they may have experienced or at least anticipate a negative experience in a healthcare setting, and being an advocate for your patients and in your everyday lives. So there are a number of organizations that organize around issues related to policy. And we have Weight Stigma Awareness Week coming up in a couple of weeks, sponsored by NEDA. So there are a number of eating disorder and obesity advocacy associations, but even on your own, you can write your city council person to propose weight discrimination legislation or being involved in small ways. So I thank you for your attention during this noontime webinar, and I welcome any questions that you may have.
Thank you, Dr. Pearl. A lot of the questions we actually have already been answered through your discussion, but we do have one that has not yet been discussed. So an attendee asks if you are aware of any research that has examined the intervention of intentional weight loss itself as a central vehicle for internalized weight stigma. So for example, how weight cycling that's commonly experienced after weight loss attempts may contribute to more internalized weight stigma in the patient, and how the healthcare provider may then have increased stigma toward the patient when they blame the patient for the weight cycling versus blaming the weight loss process itself. And the provider may also view them as non-compliant.
Yeah, that's a great question. So there are a couple of recent studies, including from my research group, where we look at changes in weight bias internalization in patients who are in a weight loss intervention program. And so the study that we did at Penn actually showed a decrease in weight bias internalization over time. And this was a long-term treatment study. So I believe it was about like a year and a half total, maybe a little less than a year and a half. So there were certainly patients who lost weight and then regained it. We didn't see an increase in weight bias internalization. We actually saw an overall decrease. It was a small decrease. And similarly, we've also looked at things like public distress related to weight on the IWQOL scale, and we find decreases in public distress due to weight when people are enrolled in a weight loss program. And I know other studies have found similar decreases, like Janelle Menzinger led a study on a similar topic where they found decreases overall in weight bias internalization in both a weight loss group and a weight neutral intervention group. The weight, and I apologize, Janelle, if I'm misquoting or misrepresenting your findings, but you know, the decreases in weight bias internalization were bigger in the weight neutral group, but overall they did go down in the weight loss intervention group. There also have been long-term studies of weight loss treatment that didn't measure weight bias internalization per se, but measured things like depression and self-esteem. And you know, when people lose weight, those metrics improve. When people regain weight, they go down again, but they don't necessarily exceed the levels that people were coming in with. That being said, to my knowledge, I don't know of like a intervention study that looked at the effects of weight cycling per se with weight bias internalization. Cross-sectionally, they're related, but I think it would be a really interesting question to, you know, if you follow people long-term, what are the effects in the moment of, you know, when people are in that phase of regaining weight or, you know, several years down the line. The question about the provider, that I also think is really important and highlights this need for training, because there are different ways of, you know, facilitating a weight management program. And certainly if a provider is giving messages to the patient like it's their fault, or they're just not working hard enough, or they need to have more control, like those kinds of messages, I could certainly see playing into some of these internalized beliefs. I also think it's possible to support people in managing their weight in a way that doesn't perpetuate those messages. So that's a kind of a long-winded response to say that the data that's out there on weight loss and weight bias internalization does not show evidence that being in a weight management program increases weight bias internalization. Actually shows that it does decrease a little, but I think it is still an open question of, you know, long-term and kind of diving more specifically into what is the provider saying and how does that affect people's beliefs, and what is, you know, the number of times people weight cycle over the course of their life, how does that affect their beliefs about themselves as well.
Thanks. So we have time for one more question. What recommendations would you have for decreasing weight stigma and internalized weight bias at the public and secondary school levels?
That's a great question. That's a lofty question. There's probably a lot of things that could be targeted. I think teacher training is really important. You know, there are studies showing teacher bias against even young students, just as how we see teacher bias for other reasons like race or gender. So I think it is a real disparity that weight is not given the amount of attention in the teacher training and the you know, bullying, anti-bullying curriculum. So I would love to see, you know, more teacher trainings or the topic of weight incorporated into bias trainings in general and specifically included in the anti-bullying curricula.
Great, thank you. Well, that about wraps it up, everyone. Thank you again, Dr. Pearl, for a fantastic presentation and for spending your time with us. And thank you all for joining in the webinar and participating, and we hope that you enjoy the rest of your day.